Lovely guys, welcome to week 9. I'll be finishing off actually the whole epi side of things, so then you'll be totally done for the entire year, which is really nice. And then we're going on to CVS stuff, which is probably actually my most interesting area. I think I enjoyed CVS the most out of year 1. All right, so our last area was diagnosis and screening. Hopefully you guys would have already been somewhat familiar with sensitivity, specificity, positive predictive value, and negative predictive value, but I'll go through them now in case. So sensitivity is the proportion of people with the disease, so like with lung cancer, that test positive to lung cancer. So if we look at the table below, the people with the disease who test positive, that's A, and this is a proportion of people with the disease, it's A over A plus C. So it's A divided by like this thing over here. In your exams, you usually have this table set out this way. So you have like the test results on like kind of the left-hand side and like the disease on like the vertical columns. But keep in mind, they might switch it up. So make sure you like, don't just like remember the A in the order, but like remember exactly what you're dividing over what else. Specificity is all about people without the disease. So people without the disease that test negative. So testing negative is D, and without the disease is this column. So it's D over B plus D. Oh, sorry. Yeah, I did that wrong in the slides. That's my bad. So yeah, make sure you have that done correctly. So the way I remember this, which is like an awful way, but it works because I remember it, but it's not great. If you think of a better way, please tell me. But like sensitivity has an N, specificity has a P, and they're like the opposite. So sensitivity is all about people with a disease. So they're the ones who are like a positive for it. Where specificity is all the people who are negative. So they're like the P and the N's are switched. It's an awful way. If you have a better way, like please share. I'd love to know. But that's the way I currently remember it right now.
Wait, sorry. Just on that, I think the way I memorized it was sensitivity has like the second letter is E, right? So that's first in the alphabet, not first, but closer to the front than P, whereas N is closer to start from P. So that's the way I memorized it.
I like that. I like that. Nice. Okay, the super important thing that you might also be asked, apart from like calculating these, is what changes and what doesn't change with prevalence. So sensitivity and specificity do not change with prevalence because they're features of the test. So like they're testing like how well the test examines if you actually have the disease or if you actually don't have the disease. So if you have more people or less people taking the test, it doesn't matter because like the percentage of like accuracy is the same. All right, then we have PPV and NPV. So PPV is your positive predictive value, NPV is your negative predictive value. And these are pretty straightforward. Positive tests for people that have a positive test, and negative is for people who have a negative test. And you're trying to get like a true positive or a true negative. So for PPV, it's people who have a positive test that actually have the disease, because that's like kind of what you want. So they've tested positive, which is here, and they have the disease, tick, tick. And then you're trying to divide it by this number. So A over A plus B. And then for negative predictive value, trying to test how well the test works if they don't have the disease. So that's D here, they don't have the disease. And then D over D plus C. So negative predictive value and positive predictive value takes like the denominator from like the test side of things. So I like to remember it by thinking like predictive is all about the test. So I have to have it over the test. Nice. And these do change with prevalence. So if we have a low prevalence, so we don't have that many people taking the test, PPV tends to be low and NPV tends to be high, like higher than normal. And if you have a high prevalence, you have a lot of people taking the test, PPV tends to be high because I guess there's more people taking it. It's like the chances of a true positive is better, and NPV tends to be low. Just keep in mind there's also a difference if you're screening versus if you're diagnosing. So later on in like year 2, you'll be like trying to work out like when to do like a screening test, when to do a diagnosis test. That becomes relevant next year, but for now, just keep in mind that these values do change, depends on like the type of test you're doing, but prevalence is a big factor that changes PPV versus NPV. All right, so for screening requirements, we generally want to screen if we have these sort of 4 categories fulfilled. So the first is the disease is well defined, because we want to screen for like a particular disease, not like for, if we like screen like for fatigue, for instance, that's kind of vague, and we don't really know exactly what causes fatigue all the time. They're like so different causes. So we want like a well-defined disease we're screening for. Prevalence is known, so we like roughly know what proportion it is in the population. There's a long period between when the disease can be detected and when the disease will be clinically present. Because screening is when you're taking like healthy individuals, you're trying to see if they have something. So if the period of like incubation or clinical symptoms is really short, it means that people will know if they're sick because they'll show symptoms straight away. So we want to make sure that period is quite long so we can like help treat before they even realize they have the disease. And we generally like to screen for like serious diseases because diseases like a cold, like we don't really care, you'll get over it by yourself. But serious diseases, you need more intervention, and treatment obviously has to be available. For the test itself, the screening test has to be simple and safe and can distinguish who has or hasn't got the disease. So that's when your, I guess, your sensitivity, specificity, and PPV and NPV come in. Screening test is cost effective because you screen thousands of people, like the colorectal cancer one, where they send all cancer to people over 50, I want to say. That's like really cheap for them to make. And there's equity of access, so lots of people can access it. And then going on to the last bit for today is about bias. So lead time bias and length time bias refers to when we catch the disease before it like manifests itself properly. So lead time bias is all about early detection. So it's like if we catch disease earlier, so like we catch cancer, let's say 1 year before they would have gone to the doctor when they would have realized it themselves. So catch it 1 year before. Then sometimes this can make survival seem to be longer. Because if we catch it 1 year before, then the point where we know they have cancer is now 1 year more than we would have otherwise. So maybe the cancer survival rate was like, 7 years. Now we think it's 8 years. So this bias is just to mean, it's like not that we've increased survival rate, but it's just that because we catch it earlier, we think we have, but we actually haven't done anything. So that's what lead time bias is all about. It makes survival appear longer. And the way I used to remember it with like lead with a D is all about early detection. You detect it earlier, therefore they survive longer. When in actual fact, they just survive the same. Length time bias is actually kind of a sad one. It's this idea that we detect diseases that are slower progressing, which is true, and they have a shorter, over aggressive diseases that have a shorter asymptomatic period. So we might detect like a benign-ish cancer that's like really slow progressing versus like a really aggressive cancer, because if it's like slower progressing, we have more of a time to like catch them, if that makes sense. Like if we do the test every 2 years, we have like more of a time we can get them. Versus if it's like a quick cancer, maybe over 2 years, it's like already done. The problem with length time bias is that we're missing those like really sharp, really aggressive diseases. And those diseases tend to be the most serious because a slower disease, usually you can treat it more. Just like by the nature it's slower, you have more options available to you. So it brings to mind the idea that screening is like really great because you can like treat the stuff you screen. But the actual fact is just because you're screening, you tend to pick up the slower diseases, which tend to be more treatable anyway. It's not because you've done anything about it. So yeah, lead time bias is all about survival time is longer. Length time bias is you catch the slow diseases first. So it seems like you can treat them better. And then the last thing you have to know is overdiagnosis. This is sort of related to length time bias, kind of. So overdiagnosis is when you're diagnosed with something that you would have never have known about if you hadn't been screened, which I guess is what we're doing it for. But B, and most importantly, it wouldn't have affected you or killed you first. So it's like if we're screening like, I don't know, all people for a really slow type of cancer. And let's say this cancer takes like 20 years for them to actually clinically manifest, but we screen them and we find it out. Then we might start treating this person for this cancer, when in actual fact, they would have died within 10 years from like a heart disease. So that cancer would have never killed them. And instead, we're giving them more harm by like treating them from something that's actually not going to affect them in their lifespan. So overdiagnosis is all about like treating when you're not meant to treat, and taking, I guess, precautions towards something that would never actually have affected the person. And that's kind of the most risky when we're doing like these slow diseases, which length time bias tells us we're more likely to have. So make sure you do know these three. They definitely do come up on exams. I think I remember a question about overdiagnosis and lead time from memory. So make sure you do know them. Lastly, levels of prevention. These are about ways we can prevent diseases. Primordial is like the first one. So it's like the very first level of prevention. And it's the very, very, very fundamental, like beginning of beginnings ones. Primordial prevention refers to the social, economic, or environmental determinants of health. So for instance, a primordial prevention would be the government building more parks. That means people will exercise more. That prevents the chances of obesity. So like very, very broad. Or the government, I don't know, institutes a new welfare policy where people in poverty get some more money, so they're less likely to, I don't know, be unemployed, and then less likely to maybe have access to certain like drugs or something, or alcohol. So like very, very broad systemic kind of institutional measures, primordial. Primary is when you're targeting asymptomatic individuals. So like you're targeting more like I guess specific people now, specific groups, and asymptomatic people, whereas primordial is like everyone. So like the Dumb Ways to Die campaign was an example of primary prevention. Secondary is all about screening. Like if they ask you, give an example for secondary, screening is your answer. It's early detection of the disease. So early detection of people who have any disease is secondary. And tertiary is when you're actually trying to like treat the disease almost, I guess. So like giving surgery for people with coronary heart disease to reduce the chances of having like a heart attack or something. Or I don't know, maybe removing the leg of a diabetic patient to reduce the chance of like the gangrene, I guess, spreading throughout the body. So tertiary is like already kind of like treatment style. All right, I just had a question come through. Can you talk about the difference between primordial and primary again? So primordial is all about like the institution kind of policy stuff before we even talking about even like specific diseases. So like planting more trees to make the air cleaner to help potentially with like some sort of like respiratory disease. Making sugar more expensive so people don't get type 2 diabetes or obesity. Very broad, very big, very institutional, and affects everyone. Primary is when we're specifically targeting particular cohorts that are asymptomatic, so they currently aren't showing symptoms, but they're like at risk. So we might be targeting, I don't know, smokers and telling them about, but they don't have lung cancer yet, but telling them about how lung cancer is bad. Or we might be specifically targeting like elderly people and telling them that they should get the flu shot because the flu shot is bad. So it's very specific for a disease, and it's very specific for like a particular cohort. Whereas primordial is just like for everyone, let's plant more trees. And I hope that makes sense. And yeah, that is it for me. I can keep sharing the slides, or David, you can share up to.
I reckon I'll share it. I'll just talk now. Cheers. Let's go to the right slide. Just before I start, I was going to do the back as well this week, but I didn't for two reasons. One is that I don't think there was a question on our exam or in any accessible way on it. And number two, I thought Peter would be better at it. So we're going to do that next week. You won't miss out on much. It's really, really not very high yield, but I'll stick with the hard stuff and Peter will take over that back stuff. This is going to be a really short session, so that's good. So to begin with, we're going to talk about hemodynamics, which really refers to blood. To begin with, we're going to break up the blood in your body in two different circulations or systems. The first circulation is the pulmonary circulation, which refers to the movement of blood between the heart over here and the lungs over here. Another word for lungs is pulmonary. And this is how, deoxygenated blood will be pumped into these pulmonary capillary beds. Oxygen is going to diffuse through, the oxygen is going to bind to hemoglobin, and then this blood is going to be oxygenated. It's going to return to the heart, and then it's going to be pumped away. And the place it's pumped away to is known as the systemic circulation. In the systemic circulation, oxygen and oxygenated blood is used to perfuse tissues and give them nutrients. And often this diffusion occurs in these capillary beds. And then after, it's going to collect waste and CO2, and that's going to be returned to the heart, where it's going to be pumped back into the pulmonary circulation, into the lungs, where that CO2 is going to be given off, and you're going to breathe it out. A couple of important points. The first important point is it's a common misconception that arteries equal oxygenated, veins equal deoxygenated. So that's not true. An artery is a vessel that goes away from the heart. So this over here is a systemic artery supplying tissues, and it has oxygenated blood. This over here is a pulmonary artery that has deoxygenated blood, but because it's going away from the heart, it's known as an artery, and it's going to the lungs. Likewise, veins are not just deoxygenated. It happens in this case in the systemic circulation that deoxygenated blood is returning back through the venous system, but this over here is also a vein that's returning to the heart. There's different sorts of blood vessels. You have arteries. Each are these big blood vessels. They're going to branch into your arterioles, which are a little bit smaller, and then these are going to branch into capillary beds. And at the capillary beds, you're going to have venules that are then going to combine to become veins. Important to know that arteries, systemic arteries especially, are often high pressure, and you can see that because they have a lot thicker muscular walls, so they can compress at a lot higher pressure. So hopefully you're fairly well orientated now. This is just making the point that artery carries blood away from heart, veins carry blood toward heart, and it has nothing to do with the oxygenation of the blood. So this is another slide, and it's essentially showing that the amount of blood you pump at any given time isn't independent. It's completely dependent on the metabolic demand of the body or what you're doing. So when you exercise, your cardiac output, so cardiac output is equal to your heart rate, which is the rate at which your heart contracts, and cardiac output equals heart rate times stroke volume, which is the volume of blood that's pushed out every time there's a pump. So that's an important concept. I just think of cardiac output as the amount of blood being pushed out. When you exercise, that's going to increase because you've increased your metabolic demand and you need more blood to perfuse your tissues, and it's going to redirect towards your skeletal muscle. So you can do more exercise and you can have more energy in those areas. Whereas at rest, you need less blood circulating in the body, and it's going to the distribution of the blood is going to change. It's an important concept, and I think that probably ask it on an exam, is that the amount of blood being pumped isn't fixed. It depends on the activity of the body. So can you think of like a mechanism that how does the heart change how much blood it pumps out? What mechanism tells the heart to do that? Does anybody have any ideas? Yeah, so great. That was really good. Someone said sympathetic nervous system, and that's exactly what I was thinking. There's obviously a lot of different mechanisms, but the first one that comes to mind is the sympathetic nervous system. So the sympathetic nervous system, like think of it as your stress response. It's so to divert blood somewhere, we just dilate the blood vessels going there. Yeah, that's true. So if you want to make blood go to a particular area, you just dilate the amount of the vessels, so the blood goes there more. There's also, that's mediated by metabolic demand. So if you're in an area of tissue that has rapid turnover, sorry, there was a question that says, so to divert blood somewhere, do we just dilate those blood vessels go in there, question mark. So the answer is yes. And a mechanism that works, one of the mechanisms is there's a few mechanisms that works by. There's a myogenic mechanism and an autocoid mechanism. The autocoid mechanism refers to like, there'll be high metabolic demand in your skeletal muscle, that's going to lead to a lot of metabolic waste. And those wastes have a function of dilating the blood vessels. So then more blood can go there because the body knows that there needs to be more demand going there. And as that happens, there's a reflex that the blood vessels will dilate as it's more blood is pushing against it. But the metabolic one is pretty cool. And you'll learn about that in more detail in 1 or 2 more lectures. And yeah, I've written mediated by metabolic demand. So, but just as I was saying before, the sympathetic nervous system has 2 effects. It innervates your heart rate. We'll talk about what that exactly means in a second. And it means your heart rate increases, which means you're pumping more blood more regularly. And it also increases your stroke volume, or the force at which your heart contracts. So more blood is being contracted, and it's being contracted at a higher frequency. So that's a good get to the person who got that. Next, we're going to talk about the types of flow, which is quite important. You have something called laminar flow, which is just straight flow, and it's smooth. Just think of a smooth river, nice and straight. Something else is called turbulent flow, which is described as chaotic flow, and it's quite irregular. So you haven't done CVS yet, but maybe you've heard the word bruits before. Often you'll get your stethoscope and you'll put it over a blood vessel. And if you hear this kind of whooshing sound, it's called a bruit. And that's due to turbulent flow. The main causes of turbulent flow can be seen here. The stenotic valve, okay, let me do that again. The main causes of turbulent flow is often constriction. So a good one to think about is atherosclerosis of your carotid artery. You can hear bruits. This over here is showing you if the valve, the heart has valves. Let me show you a heart to show you that it has valves. The heart has valves, so this over here is a valve. And the valve opens to allow blood to flow in and closes when the heart contracts so that the blood doesn't regurgitate into the atria. So what can happen is you can have pathology to these valves. So you can have stenosis of the valves, which means there's turbulent flow, and you can auscultate this. And it looks like, sorry, it's a bit disorganized, but it looks like this. The blood is flowing everywhere. And yeah, it's heard as a murmur. You can, when there's a closed valve, you should hear no flow. But when there's insufficient valve, you can get regurgitation, which is also heard as a murmur. Can anyone think of how do you know if it's a narrowed valve or if it's a leaky valve clinically when you auscultate? So what you're going to do is, if you think about it, it depends on, oh, we got answers. So we got leaky valve. So time in, lub-dub, that's true. Angiogram is true. Leaky valve is quieter. All good answers. The physiological aspect I was thinking of is, so there's 2 words. One is called diastole and one is called systole. Diastole refers to the phase of the cardiac cycle in which blood is filling in the ventricles. Systole refers to when blood is being pumped out. In systole, these valves are closed, and they're closed so that when the heart contracts, there isn't backward pressure into the atria, which is pathogenic. So if you listen during systole, which is that lub-dub answer someone wrote, is quite relevant to that. If you listen during systole and you hear, you're listening over the mitral valve and you hear a murmur, that means it's probably during systole. It's probably due to regurgitation during systole. If you're listening to your aortic valve, which is, so this is the right side of the heart. This is a right atrium, right ventricle. There's a pulmonary trunk, divides into pulmonary trunk, comes out over here, beneath this, over here. And you have your pulmonary arteries go into your lungs. Your pulmonary veins are returning to your left atrium, which you can't really see that well here, but there it's over here. And then to your left ventricle. So I know that this is the aortic valve. If during systole, I hear murmurs over here, that means these have been constricted. So that's the difference. Does that make sense? Kind of. Okay, let me try that again. So forget the clinical scenario then, just think of it physiologically. When you have systole, that means blood is in your ventricles and it's being contracted. The blood in the ventricles is being pumped to the systemic circulation. To be pumped, the blood has to go through an open aortic valve in this situation to go to the systemic circulation. If during systole you hear a murmur over this aortic valve, that means there is stenosis or it has been narrowed because blood is being pumped through it exactly. To contrast that, if you have systole, where the pressure is building in the ventricles during that contraction, and you hear murmurs in this mitral valve, sorry, the mitral valve is here, this is a tricuspid valve, but it doesn't really matter, it's the same point. You can hear it in the tricuspid as well. If you hear it during a murmur over the mitral or tricuspid valve during systole, that's a regurgitation because these are supposed to be closed. So it's not just that there's a narrowing of blood going through, because there's no blood going through here at all. There's a backflow due to the contraction of the ventricles because the valves are incompetent. Yes, sorry, that I definitely should clarify that. So one valve, you have 4 valves in your body, in your heart. You have the tricuspid valve that separates your right atrium from your right ventricle. Then you have a pulmonary valve that separates your right ventricle from like the lung circulation. You have a mitral valve that separates the left atrium from the left ventricle over here. This is a mitral valve. And you have an aortic valve that separates the left ventricle from the systemic circulation. Is that all good? Yes, no? Yep, makes sense. Why they're opposite now. Yeah, wonderful. We'll then go back for a second. One second, just looking at something. Okay, good. Happy that makes sense. Let's go back. So that's your insufficient valve. You think of this as your mitral valve during systole. The pressure in the ventricle is building up and it's flowing back into the atria. So you hear that murmur. Whereas this is you're at your aortic valve during systole. It's stenosed or constricted. So you're hearing that murmur because of that. Whereas you want your aortic valve during systole to be open like this and patent like this. Whereas you want your mitral valve during systole to be closed. So it doesn't regurgitate. Happy, I hope that makes sense because that's quite important. Do we need to know what types of murmurs we hear in different valves? No, that's high level and that's what cardiologists do. We just need to know you can hear a murmur. A murmur is a pathology of the valve. That's essentially the extent we need to know it. So there's a concept called flow, and flow is equal to pressure divided by resistance. So if you did physics, this is like current equals voltage divided by resistance, or Ohm's law. So yeah, if you think of these different systems, resistance is going to be the force that opposes the direction of the movement of the fluid. Pressure is often going to be due to like the heart is going to pump and there's going to be a pressure pushing it down, and flow is going to be a relationship between these two. One is moving in the positive direction, one is opposing it in the other direction. Just some side points to know. The velocity of flow is highest in the center of the vessel and decreases closer to the vessel wall. This is because there's increasing resistance towards the vessel wall. So as this resistance increases towards the vessel wall, your flow is going to decrease. This is important when you're recruiting leukocytes, because if leukocytes are flowing in the center, they're probably not going to slow enough down to adhere to blood vessel walls. Whereas when they go towards the peripheral, then they're going to slow down and then they can be kind of extravascated. So flow is directly proportional to pressure if the flow is laminar. So there's like a linear relationship. So think of your y equals mxc graph. If there's turbulent flow, there's a nonlinear relationship. And all you need to understand about this is if there is turbulent flow, the pressure gradient needs to be increased to maintain the same flow. In other words, if you have this regurgitation, you need more pressure, a more pressure gradient, so more pressure pushing this blood down in this direction to get the same flow as in this normal valve, where there isn't loss in the opposite direction. So the pressure gradient needs to be increased in turbulent flow to maintain the same flow. Does that make sense? You definitely, yeah, awesome. So what is pressure? So pressure refers to the flow of liquid down a concentration gradient in this context. Flow occurs from high pressure towards low pressure. So in the systemic circulation, blood will usually flow from the arterial end where there's high pressure. And this is, arterials are coming away from the heart, so blood is just being pumped from the heart. And they're going to go towards, the flow is going to go towards the venous end where there is low pressure. And as the blood vessel encounters more resistance, so let me rephrase that. If you think you have a blood vessel, its origin is in the heart. The blood vessel proximal or nearest to the heart is going to have very high pressure. As you travel along, it's going to transfer energy essentially to friction against the endothelial wall, and it's slowly going to lose like the force that it's contracting. I think that hopefully makes sense. So like the further you are away from the pump, the slower the water moves. And you can think of that not just with blood, but even with a water pump. Like the water closest to the pump is being shot out really quickly. And if it circles around towards the bottom, it's going to have a sort of stasis. So I hope that makes sense. So blood travels from high pressure to low pressure, and there's low pressure distal to the heart. The function of the heart essentially is just to maintain this gradient. This gradient, exactly. So the tunica media of arteries have a lot of smooth muscle in them to kind of withstand this pressure and also to create the pressure when they contract. Whereas veins have a larger adventitia, which is more of that connective tissue. Let's catch you right. So the function of the heart is to maintain this gradient because you need a way to get oxygen to go throughout the tissue of the body and to then return to the heart. It's also the reason why venous thrombosis are really more like quite common, is because there's less pressure in this systemic venous circulation. So there's more likely for clots to occur. The next important point is to remember that pressure, it should always be written as change in pressure or like delta pressure, because pressure is always only important in terms of the relative difference. So the 80 millimeters of mercury between 90 and 10 is the same pressure as that between 180 and 100. It's the final minus the initial, and that's what pressure is. And that is what determines flow. So the flow in these very high pressure vessels is the same as in this because the pressure difference is the same, assuming resistance is the same. I hope that makes sense. Now we're going to talk about resistance, and resistance is just an impediment to flow. These are some factors that contribute to resistance. The vessel length. The longer the vessel length is, the more friction against the wall, the more resistance that's present. The vessel diameter, similar concept, more of the volume of the blood is exposed to that endothelial wall for friction, and viscosity of blood as well, because that's harder to, more energy is required to move it. And we'll talk about that clinically in a moment. But the most important high-yield thing from this hemodynamic lecture is that the factor with the greatest effect is vessel diameter. As Katja said, the formula is really important. And what she means by formula is that resistance is proportional to 1 on radius to the 4. So if you double the diameter, you increase the flow by a power of 4. Hold on, let me rephrase that. This is for the resistance, and this is the radius. If I put 1 in this formula, my resistance is 1. If I put 2 in this formula, 2, 4, 8, 16, my resistance is 1 on 16. So it's exponentially increased to the power of 4. As a decreased resistance increases conductance or flow, if you have, let's say, a diameter, we'll talk about radius. Let's say the radius is 1 in this situation, your conductance will be 1. If you double that radius, so it's 2, your conductance will increase to 16. So it increases by a factor of 4. Does that make sense? That's where these numbers come from. These are to the power of 4. So all they're doing are doubling here, and then these are increasing by a power of 4. Makes sense. Wonderful. Tell me if it doesn't for anyone, because yeah. But if you just remember this, you'll be as well fine as well. The resistance is radius to the power of 4, and it's the most important factor of resistance is vessel diameter. This is hemodynamics. For some reason, everyone in our year level forgot what hematocrit is. So you'll be really good next year if you can remember this. But hematocrit is just the percentage of the volume of blood occupied by red blood cells. So as you remember, blood has a lot of components. It has plasma, it has a buffy coat with white blood cells and erythrocytes. Hematocrit is just the percentage of this that is erythrocytes, red blood cells. Male sex is about 45%, female sex about 42%. And that's because people of the male sex have higher oxygen carrying capacity, therefore they have more hemoglobin, so greater proportion of their blood is red blood cells. Why is this important and how do we link it back? There's something called doping. So in order for athletes to improve their performance, often they'll give themselves more red blood cells. And the reason why they give themselves more red blood cells is they want to increase their amount of hemoglobin. The reason they want to increase their amount of hemoglobin is so they have greater oxygen carrying capacity. They can meet the metabolic demand of their muscles and have greater performance overall. So this has associated with quite serious cardiovascular complications. So why do you reckon that could be if you're increasing the amount of erythrocytes? What are you affecting? It needs more pressure to pump. Yeah, so that's true. It needs more. So someone wrote, it needs more pressure to pump red blood cells because the heart is tired. And that's a really interesting way to talk about resistance. So the heart needs to pump more red blood cells because there's more resistance. And the reasons there's more resistance is as hematocrit increases, blood becomes more viscous. And because it's more viscous, there's more resistance, which means cardiac output needs to increase to maintain the same flow. Smokers do also get really sticky blood because of nicotine. Yeah, really good point. I'm not so sure about this, but the reason is smokers often get hypoxic, so they have low oxygen saturation, and the body compensates for this by increasing the amount of red blood cell production. And as a result, they have a greater percentage of hematocrit and their blood is more viscous and sticky. So that's great. Someone wrote, okay, if this is related, but don't smokers also get really sticky blood? And I wouldn't have figured that out if not in this context. So you taught me there as well. Electrical conduction overview. Oh, stop making typos. Okay. This is pretty hard, pretty important. In order for the heart to pump, it needs to be electrically coupled. The heart has a complex circuit diagram, circuit system, in order to coordinate this pumping. It's important because the heart has to beat rhythmically, so these impulses have to be rhythmic, and they also need to be able to be conducted through the heart, so all the ventricles can contract at the same time and all the atria can contract at the same time. The most important concept about this, and the reason why it can't just be everything contract, is because the atria need to contract before the ventricle contract. Why do we reckon that is? So ventricles get blood, exactly. The ventricles need to fill with blood before they're pumped out, because there's no point the ventricles contracting, but you have no blood there, or it's being like not properly pumped out. So there is a delay in the circuit system. So just to orientate you a bit, this is something called the sinoatrial node. The sinoatrial node is autorhythmic and it generates impulses spontaneously. Every however many milliseconds, a really short period of time, it's going to generate an electric current. That current is going to follow internodal pathways. There are 3 internodal pathways in the right atrium, the anterior, the posterior, and the lateral. And they all feed into this atrioventricle node, which we'll talk about in a second. There's another internodal pathway called Bachmann's bundle, which leads it to conduction and depolarization of the left atrium. Now, it is true that cardiac myocytes by themselves will conduct electrical signals through their gap junctions. But these are like little highways. They're very specialized conducting fibers. Now, the reason why I'm talking about this is because this AV node is really important. It has relatively few gap junctions, so there's greater resistance to conductance, and essentially the electrical signal is buffered here. So the atria are going to contract, the electrical signal will be buffered, blood will fill in this ventricle, then the electrical signal will shoot out to these Purkinje fibers. There's a left and a right Purkinje fiber, left and a right Purkinje fiber, and these are going to try and depolarize as many of the ventricular myocytes as possible really quickly. And then the heart is going to pump it and push all that blood in the systemic circulation. These Purkinje fibers, the signal is so quick that the entire ventricle is almost contracting simultaneously. This is going through some of the words I talked about. Sinoatrial is normal rhythmic impulses. Internodal pathways conduct from SA node to AV node. AV node is where impulses are delayed. AV bundle, also known as the bundle of His, conducts impulses from atria to ventricles, and these are in the septum of the ventricles. Septum is that connective tissue between these two compartments, and you have your left and right Purkinje fibers, which conduct cardiac impulses to all parts of the ventricle. The Purkinje fibers aren't just like this, they branch all over the place. So we spoke about this excitation in sinoatrial, internodal spreads. Yeah, we've done that. This is another image. Essentially, it's different because it shows you the heart more nicely, and it has the different internodal tracts, anterior, middle, posterior. This is your septum of your ventricle, where your bundle of His is. This is your AV node. This is your bundle of His. Bachmann's bundle takes it from the right atrium to the left atrium, so these are coordinated. Yeah, this is your tricuspid valve on your right side of your heart. This is your mitral valve by the left side of your heart. Just give me 1 second. Sorry, I just something just came out.
And I might just quickly jump in here. I had a question come through about depolarization. It's something David will chat about in a bit, but it's pretty much like just the changes of charges. Like a cell can be charged, and like when it changes the charge, we call that polarization or depolarization. And depolarization is pretty much when it gets more positive ions coming inside. But yeah, David will touch on that in a few slides.
Yeah. Everything's good, but I'll do that now. I'll just quickly show you what depolarization means. Let's find a good picture. Okay, this is a good picture. Depolarization means the potential difference between the extracellular and intracellular environment is decreasing. So a cell is polarized. The electrical charge of the cell is determined by the flow of ions into or out of the cell. If you have sodium ions flowing into the cell, sodium ions are positively charged. They're going into a negative environment and making it more positive. And so the cell is going to depolarize or become more positive. That's what depolarizing means. Repolarization is the opposite, when it becomes negative, and hyperpolarization is an overshoot, which isn't as important in this context. So just remember repolarization, depolarization becoming more positive, repolarization becoming negative. Repolarization often occurs because of positive charge going out of the cell, so it's becoming more negative. And yeah, worth revising those. I think that's Sem 1. That's probably why it's a bit hard to remember, but it's worth revising those concepts. Where were we? Yeah, we were just here. Yeah, interesting point, but it's not worth it. So it's sinoatrial node. It's located in the right atrium, really important. And it's slightly immediately below and slightly lateral to the superior vena cava, which drains into the right atrium. The superior vena cava is just like a vein that brings the systemic circulation into the heart. It's taking deoxygenated blood into the right atrium where it's going to go into the right ventricle and pumped into the pulmonary capillaries to be reoxygenated. Sinoatrial nodes have automatic electrical rhythmicity, and they usually control the beat of the heart. So this little node itself is what leads your heart to contract at the speed it does. An important note is it is not the only part of the heart that has automatic electrical rhythmicity. In fact, almost all parts of the heart, instead of some fibrous tissue and the ventricle myocardium, have this. So atrial cells have automatic electrical rhythmicity, as do Purkinje fibers, as does the AV node. The reason why this sinoatrial node predominates is it's a lot quicker. So it's going to have an action potential, lead to current flowing through everywhere, and it's just going to do that before any of the other structures can do that. So it predominates. There's an entire lecture on this next week, so don't get too stressed about that. Yep, faster rate, other parts of the heart will have a chance to reach action potential and depolarize the heart themselves. This is just talking about internodal pathways. So sinus nodal fibers will connect to adjacent atrial muscle fibers. So the conduction, these internodal fibers are like a highway. So usually this is the speed at which electrical signals travel through heart muscles. In these bands, it's much quicker. And the reason why it does that is for the Bachmann's bundle, it is to make the left atrium depolarize synchronously with the right atrium. And then you have these three other bands, just the AV node for special conduction fibers for more rapid conduction. Let's keep going. Tell me how we're doing if you want any questions. If you want a break, just let me know. AV node. The function of the AV node, as we said before, is to delay conduction so the atria can contract before ventricles so blood can fill. A point that I didn't mention before is this is only in one direction. It's really important that blood doesn't flow from the ventricles to the atrium. If it does, what do you hear when you auscultate? If you have regurgitation, you get murmurs when you auscultate, which we talked about before. That affects your mitral and tricuspid valves for regurgitation because they should be closed when they're systole or when the ventricles are contracting. So the blood can all go into the systemic circulation or the pulmonary circulation and doesn't go back into the atrium. In order to prevent backflow, there's a fibrous band between the atrium and ventricle that covers the entire connection except for this one AV node. So the only signal transduction between the atrium and the ventricle can occur through the AV node. There are some conditions where there's pathology to this fibrous band, and often that results in arrhythmias and pathology. AV node is in the posterior wall of the right atrium, usually posterior to the tricuspid valve. And it works because there's a reduction in gap junctions, greater resistance, and therefore conduction is slowed. So this is just a table with all the conduction. It's a little bit intimidating, but it's probably worth having some idea of just because it helps understanding. To begin with, you have a really rapid conduction from your sinus node to your AV node. Your internodal pathways are facilitating this. They're like highways. That takes about 0.03 seconds. At your AV node, there's about 0.09 seconds, just a delay just in the structure itself. So you've had in total 0.12 seconds, 0.03 coming here, 0.9 just waiting for the ventricles to fill. Then you have another delay in this bundle of his over here. It's also known as the AV bundle, as we said before. This is about a 0.04 second delay. So overall, there's a 0.13 second delay to allow the ventricles to fill. Once the signal reaches this ventricular septum, so we're in the septum over here, we're over here in the septum. Once it reaches there, sorry, I just waved my mouse over it, but it's over here. Once it reaches there, the difference between there to the Purkinje fibers is 0.03 seconds, really rapidly going to all parts of the heart. Purkinje fibers transmit the conduction speed the fastest, really quickly. And then this you don't need to know, but it's just for completion. And why? Then there's another 0.03 seconds in just getting it from the endocardial to epicardial surface. You don't need to know that. But that's essentially the whole time of the heart. Purkinje fibers are large fibers that rapidly transmit action potentials to ventricular muscles. They transmit at a velocity about 6 times that of the normal ventricular muscle velocity, and there's an almost instantaneous transmission to the entire ventricular muscle complex. They work through a large quantity of gap junctions that decrease resistance, so there's a higher flow. Think of Ohm laws, there's a higher current if there's a reduced resistance. They divide into many smaller branches to cover a greater proportion of the ventricles. This is a summary slide of everything we've talked about. 0.03 seconds from the sinoatrial node to reach the AV node. Here there's going to be a delay as these atria contract so that these ventricles can fill. This Bachmann's bundle over here is allowing the synchronous contraction of the left and right atrium. While these delay, the ventricles are going to fill. It's going to delay at the AV node for about 0.09 seconds, then at the bundle of the His for about 0.04 seconds. Every other surface here is covered by fibrous tissue, so blood can't flow the wrong way. Then you're going to have a really rapid, this is the left Purkinje fibers, this is the right Purkinje fibers, really rapidly transmitting to all parts of the heart. That's going to take about 0.03 seconds, and then another 0.03 seconds to get from the endocardium to epicardium, in which the whole heart's going to contract. That's it. If you got that, you're good to go. But we'll keep going in more detail. This is just describing the pacemaker activity. So the nodal action potential does not have a resting membrane potential. It's called a pacemaker potential. These have self excitation and autorhythmicity. In other words, they're self-sustaining. There's a slow depolarization between action potentials in these as compared to in a ventricular muscle. It's spontaneous, and there's also spontaneous depolarization, spontaneous repolarization. The atrial muscle, SA node, AV node are all like this. The reason why the SA node predominates is it depolarizes more quickly, so it doesn't give a chance for these other structures to depolarize the muscle. And ventricular muscle is completely different. It works like the other muscles we've learned about before, and I'll go into more detail in a second. You're doing really well. So this is a comparison of ventricular muscle to sinus nodal fibers in terms of the action potential. Ventricular muscle has a stable resting membrane potential of about -90 millivolts, and it's going to stay here until the gap junctions, there's an influx of signal by the gap junctions that's going to lead to calcium slightly repolarizing. And when the membrane potential is greater than 90 millivolts, fast sodium channels are going to open and there's going to be a quick depolarization. Positive sodium is going to rush into the cell and lead to the cell becoming more and more and more positive. Eventually, that's going to keep occurring until a plateau occurs. At the plateau, calcium channels, L-type calcium channels are going to open to sustain that plateau. And then eventually, slowly, the calcium channels and the sodium channels are going to close, and the potassium channel is going to predominate to lead to a repolarization to return it to resting membrane potential. You can see that it starts, the ventricular muscle gets more negative and more positive than the sinus nodal fibers. It also reaches, these peaks are more quick. You can see the gradient is more steep. Has a large gradient, so that's so quicker. There's depolarization over time. The pacemaker action potentials have no stable resting potential, but rather this over here is called a pacemaker potential. In the literature, this seems quite not as clear, but in the lectures it says that, so we believe that. It's less negative and less positive than the extremes of ventricular extremes. So how does this all work? So for cardiac muscle and for a ventricular action potential, fast sodium channels lead to that upstroke. That upstroke is when it goes up, sodium goes into the cell. Calcium or L-type channels contribute to the plateau. They're also called slow calcium channels. And then you have potassium channels, which is the efflux of positive potassium channels lead this to be more negative. For nodal, your pacemaker potential is about negative 55 millivolts. You have something called, it's really interesting. So because you're at this negative 55 millivolts instead of this negative 90 millivolts, your fast sodium channels have been inactivated or blocked. They no longer function to lead to this quick depolarization. So instead you rely on something called slow sodium, also known as funny currents. And these funny currents will lead to this increase of this action potential, increase of this pacemaker potential until as the depolarization occurs. So only slow sodium and calcium open and cause action potentials, which is why it's a slower process and why atrial nodal AP is slower to develop in ventricular. The return to the nodal negative state is also much slower than ventricular muscle returning to action potential. So this gradual decline is much slower than this as well. Almost done. You're doing really well. This is the last. I try not to make slides that are hellish like this, but this is pretty like step by step by step. Just look at the bold and don't get too overwhelmed. Funny current is sodium that leaks through open sodium channels down a concentration gradient. It's a more slow process. The fast sodium channels are unavailable. Remember that? And that's going to go from about negative 55. When the potential reaches about negative 40 millivolts, L-type calcium channels are going to activate. This is going to lead to that action potential. And after a certain amount of time, those will eventually close. While those are closed, the potassium channels are opening and positive potassium will diffuse out of the fiber. This is reducing the potential back to pacemaker potential. So the cell is becoming more negative. And hyperpolarization, which is the overshooting of cells going out, will lead to negativity because the cell will notice, okay, I've reached my resting membrane potential, but it takes time to close. So it overshoots it a little bit just for that lag in closing. The potassium channel will eventually close, and then this depolarizing effects of funny currents and calcium ions will predominate. Funny currents, they're slow sodium diffusion. Self-excitation, therefore, is caused by the leakiness to sodium and calcium. We're almost done. This is just an example of what I've spoken about visually. I took this from the lecture. The lecture does this, but it breaks it down in these really visual steps. So it's hard to connect, but it's nice to see visually. Sodium diffuses into the cell. That's responsible for the upstroke. The sodium channels, fast sodium channels, open about negative 90 millivolts. This is just a comparison. I think this is the last or second last slide. This is the last slide, so you've done really well. This is just comparing pacemaker potential to ventricular. Pacemaker is initiated by funny sodium channels by about negative 50. At about negative 40 millivolts, there's L-type calcium channels open and allow calcium to diffuse in, leading to the action potential. Then there's a gradual decrease. Then potassium is going to open and predominate and lead to repolarization. And then eventually there'll be a gradual decrease in output potassium, leading to repolarization again. What I'll just do here to make sure there's no confusion is I'll add in another step, which is potassium channels. Polarization. Sorry about that. I know it's unprofessional to do this, but it's better to clear confusion here and now. Okay. On the other side, what is pacemaker potential? Really good question. Happy you asked that. Pacemaker potential just refers to the autorhythmicity of areas of the heart that have a spontaneous depolarization or spontaneous repolarization. Examples of pacemaker activity is seen in sinoatrial nodes, which are kind of self-sustaining. This depolarization occurs automatically. Repolarization occurs automatically. Depolarization is like a pacemaker activity. It goes continually. It doesn't require external stimulus, which is in contrast to the ventricular muscle fibers, which need calcium to transfer through the gap junctions in order to release the calcium from the sarcoplasmic reticulum to unbind the troponin, those troponin complexes. So it's independent, whereas this is dependent on external action potential stimulating it. Over here you can, does that make sense? Yeah, also no worries. So over here you can see fast sodium influx leading to uptake. Plateau is by calcium opposing potassium, and then repolarization is by potassium going outwards. And that's all we got. How long was that? An hour. Okay, that's way long.